You're most welcome to this session this evening or this morning for some people, wherever you are. So good afternoon, good evening, or good morning. This is the second panel for the African plenary, rather, for the AfriHealth Conference. We are two chairs for this session. Myself, Nelson Sewankambo, and my colleague, Professor Mosa Moshabela. He will introduce himself so that, because I may not do justice to the introduction. Let me say just a few words about myself. As I said, I'm Nelson Sewankambo, Professor of Medicine at Makerere University in Uganda. My background is in internal medicine and infectious diseases. I have been in Makerere for a long time. But for our purpose today, my colleague is going to do most of the work regarding this session. The session, and I'm sure you all know, it's all about epidemiological transition and disease burden of COVID-19, and that's going to really shape the session this evening. There was supposed to be non-communicable disease, HIV, and Ebola, but I think given the topics we have with the three speakers, it will be mainly or largely on COVID-19. Our three speakers, I hope they will keep to time so that we have enough time at discussion. And at this point, let me hand over to Professor Moshabela so that he can give us, introduce himself, of course, first. Do also give us the housekeeping rules, as it were, and then take on the presentation from there. Professor.
Thank you so much, Professor Nelson Sewankambo. Much appreciate. It's an honor to share this panel with you. And I would like to also welcome our panelists, welcome all the attendees present today. And from wherever you are in the world, you're most welcome and greetings to you. My name is Mosa Moshabela from the University of KwaZulu-Natal in South Africa. I am the acting Deputy Vice Chancellor of Research and Innovation here at the university and a Professor of Public Health. So I would like to really take this opportunity to thank you for the invitation to be here, but also to thank you for your presence. And we're looking forward to an engaging discussion. We are going to get three presentations, and I would like to request that for each presentation, just insert your questions in the Q&A and our panelists will engage with you there. And then we'll go through all the three presentations, and at the end, we will have a discussion if we've got some time. But my hope is that we will have some spare minutes to have a discussion at the end. But let's try and engage also in the Q&A as issues come up. Without wasting time, let me invite Professor Emilia Noormahomed, who is a professor of human parasitology at the Department of Microbiology at the Faculty of Medicine at Mamtani University in Mozambique, and also an invited professor at the University of California, San Diego Infectious Disease Division. We're very honored to have join us. Emilia is a long-standing member of AfriHealth and a founding member of AfriHealth, and has been involved with the MEPI program since 2011. And through that was able to establish a cysticercosis working group for Eastern and South Africa, and really has now been very actively involved in subsequent work that has emerged out of the work that MEPI has been doing. And within the country, she is now appointed Dean at the University of Mamtani Faculty of Medicine, and also Vice Chancellor at Lurio University up until 2017. So we really have a highly esteemed speaker today, and we're looking forward to this presentation. Professor Emilia, welcome. You can project live and take us through your presentation, and we can engage in the Q&A. Thank you very much.
Thank you, Professor Mosa. Thank you, Professor Nelson Sewankambo. So, yeah. Good afternoon. Is it there?
Yes, it's good.
Okay, so good afternoon, everyone, and good morning for in the other part of the world. It is with great pleasure that here to share our COVID situation in Mozambique, but at the same time, with big sadness because we lost, because of our dismissed colleagues, Professor James Atkins and Professor David Olalai. Both of them were MEPI PIs, and together we created this AfriHealth Forum. So may their souls rest in peace. I would like also to thank the organizing committee for inviting me to share our situation in Mozambique, and at the same time greet my colleagues from the panel, Professor Nachega and Professor Ravinder Mamtani. So I will talk a little bit about the evolution of the SARS-CoV pandemic in Mozambique, challenges, opportunities, and changes towards strengthening the health system. My presentation outline will consist of a small background. We don't have much time. Challenges, Mozambique past and current situation, transformational changes and innovations, and looking ahead and conclusions. As you all know, we are located here in Southeast Africa, and with 28 million people, the majority are people living in rural areas. And despite that Mozambique is rich in natural resources, 62% of its population lives below the poverty line. And it is known that in sub-Saharan Africa, and including Mozambique, we have a shortage of health workers. That's why we are here. That's why we engaged into MEPI and then HAPI. And the disease profile also, it's one of the infectious diseases, including HIV, TB, malnutrition, and non-communicable diseases. Since the beginning of the COVID-19 pandemic, Mozambique took several measures to combat and contain the spread of the virus and dampen its collateral economic damage by taking all measures, universal measures like physical distancing, personal protective equipment, and so on, and even closed the schools and the universities and its borders. Nevertheless, the virus continued to spread globally, and on 22nd March last year, the first case imported from United Kingdom of a 75-year-old male was diagnosed in Mozambique's capital city, Maputo. Innovations for healthcare delivery and training of health professionals were introduced and included increase the interval for chronic outpatients follow-up visits for chronic diseases such as HIV, TB, high blood tension, diabetes, and provision of enough drugs to cover the long intervisits intervals. Rapid expansion of a system of telemedicine and other programs to assist the patients whenever they need it from home, and the development of e-learning tools to train health professionals. The measures described above helped to slow the progression of the infection and reduced the overloading of health system and premature deaths. As the pandemic has moved through the country, deaths have occurred amongst both senior and junior physicians, including some lecturers, our colleagues, and other health professionals. What is the current situation? The current situation now is terrifying, as the country experiences the third wave of infections, presumably due to the Delta variant. The Mozambique epidemic is similar, has followed the same pattern as the other neighboring countries, as you can see here in this table, like South Africa. Well, South Africa has much more reported number of cases, but whenever South Africa had the waves, Mozambique, Zambia, Eswatini, Malawi experienced the same situations. As for yesterday, the numbers are this one. And what we have in terms of statistics is that children, until June 30, children aged 0 to 14 years represented 91% of all cases reported. While we know that in some settings, children are much less infected, this is not our situation. We don't know what is happening right now in July, because this, since July, as you can see, we had 3-4% of infections that occurred since the beginning of the pandemic, but 38% of deaths. So really the situation is scary, and the graphs here shows how the new cases are progressing, and also the deaths. So much cases we have, much deaths we have. And the numbers are still growing, and it is expected that the cases will pick up in September. So at that point, what we will do? These graphs also is of Mozambique, but also shows the neighbor countries, neighbor countries, South Africa, Malawi, Zambia, and Eswatini. And also you can see the same situation. South Africa is the one that reports a higher number of deaths. It is difficult to understand why we present so few numbers, reports, but despite the limited testing capacities, we are observing some colleagues in the field observe some deaths that are difficult to say what is the cause, and we think that could be also some of them COVID-19. But our challenge is limited, our reporting is limited by the capacity of testing, screening our population. In April this year, we start to roll the vaccines, and at that moment, we have 1.1% of all eligible population vaccinated. And once again, I present these figures comparing what is going on in Mozambique, South Africa, and other neighbors. In South Africa, of course, it's always having more reported cases, more deaths, more people vaccinated, but also we know that it is the potency in our region. What are the challenges that we are facing? So we know that successful containment of COVID-19 is heavily dependent on accurate diagnosis, efficient population screening, and preventive measures, including vaccinations. The COVID response is exacerbated by previously existing pandemics, which rely on international support for control, as well as by military conflicts that we are experiencing in the central part of the country and the terrorism in the north part of the country. The critical congestion of public transport, markets, etc., that we know, and this is a situation that we see also in other underdeveloped countries, poses a great challenge. Despite knowing the risk of exposure, the population cannot sequester if they are to meet their subsistence needs. Infection rates of health professionals in some settings are high, further challenging our chronic staffing shortage and challenging healthcare delivery. Fear of health professionals and people in general to contract COVID-19 or infect their families have had psychological effects. Mass vaccination is limited by availability of vaccines. Fortunately, because of the structure of our health national system, we have developed all chain of the vaccination programs until the most remote parts. But now what we experience is the shortage of vaccines to massify the distributions. But also there are some reluctant people who don't want to be vaccinated or takes one dose. For instance, last week, the Minister of Health says that we had 23,000 people who went for the first doses and didn't go for the second doses. And this also may be because of conspiracy theories, side effects that some people experience, and they are afraid to go for the second dose. Further, there is a fear of contracting COVID-19 in health facilities, and this has led patients to avoid elective care and to request premature discharge. This unexpected and unprecedented emerging disease has forced us to explore and develop innovative ways to train health professionals across the country at lower price. So this was in terms of innovations we use in the past, but now we use more distance learning tools, applications such as WhatsApp text messages. And this helps us to reach the most remote places, reduce the inequities, and make better use of those trainers that are in shortage in our countries. The use of alternative ways for healthcare delivery, like telemedicine, distance learning was fostered. Improvement of and widening in the scope of message for SARS-CoV-2 infection prevention are equally preventing other respiratory diseases as well as other diseases transmitted by oral fecal means. And the collaborations with international partners through webinars for sharing knowledge and experience in diagnosis and management of COVID-19 patients, including the use of new drugs such as remdesivir, which was donated by Gilead Foundation for Health Professionals, and updates of the new vaccines were fostered. So these are the innovations that COVID-19 pandemic forced us to do or to develop. So looking ahead, although Mozambique's COVID pandemic has so far not been as dramatic as in South Africa, Brazil, and then a number of other countries, we believe that the number of cases and deaths in Mozambique, as said before, is underreported due to limitations in diagnosis, mass screening, and reporting, especially in remote rural areas. A parallel increase in the number of deaths of unknown cause supports the premise that COVID morbidity is underestimated. Our health systems is already overwhelmed and relies heavily on international support for ongoing programs to control other epidemic diseases that we have, including the vaccines for children. Therefore, there is a little room for additional challenge of COVID-19. So, research on how to better communicate with community about the causes of disease, preventative measures, especially in very crowded settings, should be a priority. It is equally important to develop measures to help people deal with fatigue caused by the social and physical distance, conspiracy theories in view of future gains, which are decrease of infections and deaths until the pandemic is stabilized. Future clinical and epidemiological studies on COVID-19, including its complication and sequelae, as well as COVID's interaction with endemic life-threatening diseases in our settings, should also have a priority. The speed of COVID-19 is still going on and forces governments to reopen economies and social activities to counter increasing poverty rates and financial losses and social isolation that are inevitable, that are the inevitable results of general lockdowns. Mozambique's government, in combination with private sector, civilian society, and NGOs, continues to work to contain the speed of the virus, to mitigate its impact through implementation of screening, quarantine, law decrees, and protocols, and to launch mass vaccination programs. Regardless of the personal risks associated with shortage of protective equipment and viral testing, critical healthcare workers continue to work on the front lines and others of our health systems to manage patients regardless of their COVID-19 status. Furthermore, the global COVID-19 pandemic stimulated early career stage researchers to study different topics that include the clinical and epidemiological aspects, as well as social and economic consequences of the crisis, including approaches to reduce vaccine hesitancy and counteract widespread misinformation about the disease. Lessons taken should help to strengthen our health system so that we will better prepared for future pandemics that are sure to come. With that, I finish my presentation and thank you for my team who participated in the preparation of this. Thank you so much.
Thank you very much, Professor Emilia. That was really incredible and sobering indeed. I am going to hand over to Professor Sewankambo to introduce the next speaker, and then we'll continue to engage in the Q&A. Thank you very much.
Thank you very much, Mosa. Our next speaker is Professor Jean Nachega, but I've not seen him yet.
He is here.
I'm on.
Oh, fantastic. Thank you. So Jean is well known in Afri-Health circles. He's a professor of infectious disease at Stellenbosch University and Johns Hopkins School of Public Health, as well as at University of Philadelphia. Besides infectious diseases, he's also an epidemiologist. And he's a very active researcher in HIV and now in COVID. He has been active in the MEPI program, Medical Education Partnership Initiative which ended some 4 years ago. And now he's very active in AfriHealth. He's a member of the Governing Council of AfriHealth, and he's also the chair of our research committee in AfriHealth. He is going to be talking to us this afternoon regarding the COVID-19 research in Africa, which he has been leading, bringing together researchers from across several countries in Africa. If there's one thing that has brought African countries together in terms of research, certainly COVID is one. Welcome, Jean, and the floor is yours.
Thank you, Professor Nelson Sewankambo, and hi, Professor Moshabela and Professor Emilia. I'm very honored to share this panel with you all. And I'm gonna get started and just share with you our, over the last few months, our collaborative research on COVID in children and adolescents, but also pregnant. So as you know, this all started, this collaboration started after some of our colleagues and myself published a paper on clinical characteristic and the outcome of COVID in Africa. We tried to look at what the early insight from data from the Democratic Republic of the Congo. In this data, as you can see on this slide, it was about 800 patients, and but a very small number of children, 34, were below 20 years, children and adolescents less than 20 years, and there were 12 pregnant women. As you can see on this slide, the time to event figure show you that it was quite shocking to us to see that children and adolescents less than 20 years, mortality, the hazard of death were higher than age group of 20 to 40 or 40 to 60. They were just a bit lower, below the elderly, which was quite surprising compared to what we know from data from Europe or from United States. So this did trigger, basically galvanize us. We discussed under AfriHealth member at the research committee, and it did trigger us to design two protocols, which were, and the two paper actually calling for really the need to pull data across the continent, because with those small number from early data from DRC, it was difficult to be a bit conclusive. So the first paper was published on pregnant women in American Journal of Tropical Medicine, and the second in CID, and it was very collaborative call for action by AfriHealth member across doctors, nurses, pharmacists, and lab scientists. And this just focusing on a topic of children, what do we know so far? So most of the data came from China, Europe, and Asia, which show basically that about 1 to 5% of all cases are in children between 0 and 90 years old. You just learned from Professor Emilia that in Mozambique, it's about 9%, so quite higher than basically what our colleague from the West found. Obviously, the symptomatology is somewhat similar, but there were really not much data coming out from Africa. The largest were from a cohort from South Africa, 159, by Marieke van der Zalm from Stellenbosch, which they did not document much casualty, but there were a significant proportion of children ending up in the ICU. And another series of multi-inflammatory syndrome, also from South Africa, 23 children. Also, what do we know at that time about the outcome? Overall mortality from children is very low, about 1%. Even in hospital mortality is about 1% documented in China or in Europe and US. So we say Africa things may be a bit different because of other comorbidity and HIV, TB, malaria, non-NCD, rheumatic heart disease, diabetes, asthma, malignancy, and our relatively weak health system may impact outcome in our continent. So there was really an urgent need to try to assess this question in our population, and that did trigger us to investigate with the support of AfriHealth this question. So we launched a retrospective cohort study, so just relying on routinely collected data from several countries. So our predictor basically were looking at age, sex, pre-existing comorbidity, and region of residence. Our outcome measure were primary outcome were intensive care unit admission and supplemental oxygen. Secondary outcome were hospital mortality and hospital discharge. We use several statistical techniques, including the classical logistic regression, but also more sophisticated analysis technique like the competing risk analysis using proportional hazard model from Fine and Gray. So these are basically the sites and the country where we operated, and this was selected based on some tie we have with several countries and collaborator, and basically leveraging the legacy of MEPI country and collaborator in those countries. Just for South Africa, we have Professor Kruger at Stellenbosch. KwaZulu-Natal, we have Professor Masekela. In DRC, Professor Jean-Jacques Muyembe. In Uganda, we have Professor Musoke at Makerere. In Kenya, we have a PI Onesimus Gachuno. In Nigeria, we have Prof Lawal at, and in Ghana, we have Prof Evans. So as you can see, number of patients recruited was about more in South Africa because the epicenter of the epidemic in South Africa. Overall, 450 children, adolescents were involved, included. The median age was about 6 years. ICU admission or oxygen supplementation was about 1 in 3 children require being admitted to ICU. About 30% unfortunately die in ICU, just to let you know. Pre-existing comorbidity, you can see majority were malignancy, hypertension, and others. So this is a figure showing overlapping of comorbidity. And this just show you stratified by region, admission to ICU, our primary outcome or need for mechanical ventilation. Again, South Africa tend to have more people admitted to ICU and being ventilated, probably because of relatively stronger health system and access to pediatric ICU. Probably that's the reflection of this figure. In logistic regression, so independent factor for need for ICU or oxygen therapy were age below 1 year. So that was quite strongly significant. Asthma, chronic kidney disease, hematological disease, including sickle cell anemia, active tuberculosis, and HIV infection. And those are quite high adjusted odds ratio, even if on some of them, the confidence interval are relatively wide. So as I said, about 80% overall mortality, including 30% of those who require ICU. So, and in-hospital mortality was again associated with lower ages, less than 1 year, male sex, multiple comorbidity, and also residing in East and West Central region, as shown on those competing risk time to event analysis. As you can see, a stepwise increase in hazard of death with increase of number of comorbidity in those children, but also the difference, the really threshold, strong threshold, the effect of age less than 1 in this population. Again, this is the stratification by region. Again, East and West and Central Africa not faring well compared to Southern Africa. Again, this may just be a reflection of the relatively weak health system in the other region compared to Southern Africa region. And when I say Southern Africa region, basically South Africa, because that's the only country representing Southern Africa. So we concluded that child morbidity and mortality in this relatively large multi-country study on COVID was substantially higher than measure reported in non-African setting and were associated with younger age, region of residence, active TB, HIV, and selected comorbidity. And really, this finding from AfriHealth are the first new data in the pediatric at large scale in Africa. And they're going to be important as we discuss policy on the continent about which population to prioritize for COVID preventive, like vaccine and therapeutic intervention, when this is going to be available widely in our setting. So I will end here, and just in memoriam, acknowledge we already keep mooning the loss of Prof. James Hakim and Olaleye, but I want to remind you also we lost Prof. Biranu Ayele, was our first biostatistician working on this AfriHealth multi-country study. He was originally from Ethiopia and with a tenure at Stellenbosch University. He was the coordinating center director of this project and data manager. And also just to acknowledge the support by Fogarty and all the PI at the country and collaborator, and also Kawisa. Thank you very much.
Thank you very much, Jean, for that very informative presentation. It draws our attention to the problem of COVID in children, so that we need to pay greater attention to that. And it's also, very rewarding to see that AfriHealth is the one bringing attention to this problem of children in Africa with greater morbidity and mortality than what we have been thinking about before. With that, let me hand you back to Mosa to again lead us through the next presentation and the discussion and QA thereafter. Mosa.
Thank you very much, Prof. I also want to acknowledge that presentation for really shining the spotlight on the problem of COVID in children. And this is currently the discussion internationally, but for AfriHealth to actually bring this issue to the world is really fantastic. Much appreciated. So now I have the privilege and honor of introducing Dr. Ravi Mamtani. Many of you will know the name, given the work that Dr. Mamtani has been doing and the contribution in public health and global health generally. Dr. Ravi is well accomplished with many qualifications around the fields of public health, preventive medicine, occupational medicine, lifestyle medicine, and integrative medicine. He is the fellow of the American College of Lifestyle Medicine, and he has been involved as a professor of population health sciences and medicine in global health at Cornell, and also serves as the vice dean of population health and lifestyle medicine. So there is the CV is quite long, and many of us understand that the contribution that he's made and continues to make is really important. Dr. Ravi, I would like to take this opportunity to thank you for accepting our invitation to AfriHealth and taking the time to engage us and our audience, and really looking forward to what you have to share with us. Please go ahead, share your presentation and address the audience. Much appreciated.
I take it you can see my slides?
Yes, we can see them. Absolutely. That's great.
So I want to begin by thanking you for that very generous introduction. I usually introduce myself as a human being with an interest in health and disease. That's as far as I go. But it's very nice of you, very kind of you. And I want to thank AfriHealth for extending an invitation to me to talk about public health in the context of what we are seeing. The title of my talk is, I'm going to focus on essentially two things. I have no financial relationships. As I tell people, I wish I did, but I don't. So I'm going to focus on two things in the next 10 to 15 minutes. And because of time constraints, I apologize if I appear disjointed. The reason is the time constraint is what it is, but I will do my best I can. So I will briefly talk about the lessons that we in the world have learned from this COVID-19 pandemic. I'm going to spend the first 7-8 minutes on that. And then from that, I'm going to see and perhaps discuss how we can prioritize our public health actions that we've been taking. And then finally, a couple of slides with some recommendations for us all to consider as we move forward, knowing, as many people would say, that there will be another pandemic, but we shall see. So I want to begin by defining public health. And I know this is a very esteemed audience, but I usually tell stories, and my stories begin with 101 ABC. So I apologize to you. To me, this is what public health is. It is basically the art and science of preventing disease, prolonging life, promoting health through organized efforts of society. The gist of this definition tells me that the players involved in public health actions, be it COVID-19, be it chronic disease control, are society, i.e. people, professionals, and those who run the programs, namely government. There might be other agencies. And of course, we do this in a variety of ways. And as I list, education, community engagement, researching, those two presentations were outstanding. I mean, I hope I was just blown away with the quality of those presentations. I hope I can live up to your expectations and the expectations of the audience. But this is what we do in public health. Now, I want to begin by first of all reminding us the lessons that I learned 10 years ago, 15 years ago, in terms of what these famous 4 pandemics did to us. They were caused by a new agent. They spread rapidly. They were difficult to stop. They were mitigated to a point, but pandemic, once they begin, as we know, you cannot stop them, you can slow them down. The death rates were high. There were 2, in some situations, 4 waves. They love poverty and inequities, as was pointed out. And the healthcare systems get overloaded. And as was mentioned earlier, there is gross disruption of our social and economic sectors. But what else it does, which I think COVID-19 has exhibited and displayed? Fear and confusion. Now, that being said, I'm a optimist. Of course, there are things that we can do. We brought an end to the major problem on this planet. The smallpox was eradicated. We have done reasonably well, I think, with polio, as we all know, and we did quite well with H1 and N1. So how was COVID-19? I think it was slightly different because we are a sensitive world. We are more educated. We have more science working to our advantage. We've learned a lot. And this is, so I won't go into the details. Again, we know that it hit us directly, causing a lot of mortality. Looking at statistics from 3 days ago, 200 million cases, 4 million deaths. We are seeing, I think it's an entity in which there are two diseases, as was pointed out. There is the one that you see among the young people, and then you see the one among the elderly or those with comorbid conditions. And of course, there are variants, there are vaccines, there are issues, and there are a lot of uncertainties surrounding COVID-19, specifically issues concerning immunity. How long does the immunity last for following infection or after vaccination? Transmission, there was a lot of discussion, confusion about the asymptomatic carrier state, as we all know. And of course, the recent stories surrounding variants, including the Delta, which was mentioned earlier. But the two things that they have done, which I think we as public health officials need to pay attention to, they have exposed cracks in our healthcare system, resulting in issues such as syndemics. I'll talk about that in a second, inequities, and hitting us right in all the sectors. And of course, I want to take a minute or two and talk about the misinformation and how that may have also upset a lot of people around the world. This is a very simplistic presentation of what COVID-19 has done. I've kept it simple. You can basically see that it has disrupted everything. It has affected chronic care disease. It has affected our mental health. It has taken away jobs from people. Economy has been hurt. It is having an impact on food. The amount of malnutrition that we will see or beginning to see in some of the low-income nations is profound. And as I said, the issue, and this was mentioned earlier, about malnutrition and availability of vaccine. The two things that I think I will spend a couple of minutes on are what we call as the excess mortality. What has it done to mortality other than mortality due to COVID-19? And also how it has affected the already existing inequities that we see worldwide. And I'm going to, again, just share with you some examples, some data for us to understand. Now, this is from US CDC from about 8-9 months ago, but I think the numbers haven't changed. Maybe there's percentage. We know that approximately, as we understand now, about 25 to 30% of excess deaths due to factors other than COVID-19. That's where we stand. So obviously, COVID-19 is killing people. The cause of mortality is COVID-19, but in the way it's acting, delaying care among those with chronic conditions, it is causing a mortality of 25 to 33%. And there is a lot of discussion on that in the Lancet, New England Journal of Medicine, on what it's doing to other conditions. This I got from a write-up recently, July 21, 2021. This to me is so disturbing. I'm a human being first and then a doctor. I'm also a public health professional and also a doctor. When you look at statistics like this, it worries me. It worries me that it's hard for me to live with these statistics. And I think this was alluded to. And basically the title of this is Striking Inequities in Low-Income Nations about the availability of vaccine. So here's a statement: only 1.7% of global vaccines have been administered in Africa, despite the continent making up 17% of world population. Now, we could have a discussion on this for days and days, but looking at the statistics, the way it appears is simply not right, is what I would argue. Now, this was Dr. Marshall. This was for the first time written up in the Lancet editorial in 2017. And I think even though we have been talking about about mortality, social determinants, but nobody ever discussed this as eloquently as Dr. Marshall in his editorial in the Global Health in the Lancet in 2017. Basically what he said was, this is a very simplistic illustration of the point he was making, that when you have two pandemics colliding, and that too in unjust situations, i.e. social substrate of, for example, poverty, inequity, economic conditions, the equation is not 1 + 1 = 2, it's 1 + 1 probably greater than 5, 6, 7, or 10, or 8, 12. And this is what COVID-19 has displayed for us. Of course, there's inequity, but what it's doing is just humongous. And again, this is just a compilation of some of our recent work that we published in Epidemiology Infection, a couple of journals. We also published recently an article entitled "The Single Most Important Lesson from COVID-19, Take Public Health Seriously." And I'll talk about that in a second. But here's a listing of things. And I'm sure you would appreciate this with your research, with your knowledge, and tremendous understanding of this. Obviously, social economic sector has been broken. Lifestyles have been affected. People are gaining weight in many situations. Isolation, distancing, consequences, depression, suicide, substance abuse, children's education, domestic abuse, and as I said earlier, delay in chronic care. Now, I wish that the world was such where if somebody said something about the evidence, that it would be taken keeping in mind the evidence and no more. Well, we're human beings. We have perceptions, we do things, we receive information, and this is what it has done. Fear and anxiety related to uncertainties which exist with COVID-19 are legitimate, of course. However, when you twist that information, calling COVID-19 snake flu, killer disease has been, that is completely unwarranted. What does that do? Leads to misinformation, even disinformation. And this misinformation, if it stays with you, will result in rumors which, once established, are very difficult to fight. And an example is most with COVID-19. Well, I won't name the country. I was in this country, and people at a bus stop was saying, well, if I get COVID-19, I'm going to die. And when we sensationalize an outbreak, in this case, COVID-19, it belittles the scientific truth and consequently does three things: threat to the true public understanding of the disease, fear and loss of control, and it affects healthcare utilization. People are either afraid of going to the hospitals, or some will go, any small minor symptom, they would show up in the emergency room. Well, we haven't taken public health seriously. That's why I think there's this discussion about what's happening to us the way it's happening. And I say that I can come back and talk about this, the evidence for public health. But I will say that the most important thing about public health is, and this is a nice summary that appeared in Community Health and Epidemiology, a BMJ journal in 2017. For every £1 or dollar spent, there's a return of 14 pounds or dollars. And the conclusion that public health interventions are cost-saving, offer substantial return on public health investment. And I'm talking about return in terms of long-term health benefits and societal benefits. How could we then argue with public health interventions? And therefore, I think it's important that we put things in perspective. In the recent write-up that we published about 2-3 months ago in the Journal of Global Health, we asked the question, how well are we prepared? So we looked at 3 criteria: public health education and medical school curriculum, research, and investment in public health programs. This was eloquently addressed. I won't spend time on it, but I would summarize that this is all done very poorly. And we know that. I see it. I'm a public health guy. I teach. I've been teaching for about 25, 30 years. And what we see is simply not acceptable in terms of investment in programs, research, and also our teaching. This is, I take this quote from the Lancet, recent Lancet, which basically says there's no silver lining to a pandemic, but there may be silver linings in the lessons learned if we prepare with a new mind frame responsible for one another and for the planet. And I think it was said very nicely. And I think these are the recommendations, the last two slides. And again, it's from different sources, WHO, GOAN, WHO Network, and also some of our write-up. Relying on evidence-based public health actions is extremely important. Of course, some measures, temporary measures such as lockdowns and closures have been helpful. They help us buy time, but they do not offer long-term solutions. And please, of course, there are clinical factors, but there are also non-clinical factors. We call them social, environmental, cultural factors. So let's not forget the big picture in this COVID-19 and the lesson that we've learned. We're living in a changing world. There is this chronic disease pandemic. There are social and economic and environmental determinants. And of course, we have pandemics, new illnesses coming up. I mean, if you look at the literature, this is American Journal of Public Health 2014, makes the same point. It's not just about clinical factors. It's a nice 3 major studies that have happened, published, to say that there is more to disease other than just the simple way of looking at it. And these are clubbed under behavior, social, environmental, and other factors. Discouraging politicization of public health response is important. Bringing in local expertise to me is important. We don't have to go outside, but everyone is smart enough, whether it's low-income nation or middle-income nation. We need to invest in workforce, education, research, and basically appropriate research aimed at public health. I also have gone as far as saying that all citizens on this planet, somehow I wish it would happen, whether it happens in school or in colleges, should go through a health and disease 101 course maybe. I think it will help us a lot. Ensure equitable access to care and champion multilateral action and international solidarity. This was a beautiful write-up in New York Times. I loved it when I read it. If you have a few moments, please read it. April 9, 2020, the US approach to public health characterized how it was neglected. And finally, they ended up saying, time to give new life to an old idea. A strong public health system is the best guarantor of good health. We saw that. We did that with smallpox eradication, and we can do it again. And with that, I want to conclude my remarks, and I want to thank you for listening to me. And again, once again, my appreciation for inviting me to this very important conference. Thank you again. I'm going to stop sharing my slides and we'll be glad to take any questions and or comments that you might have.
Thank you so much, Dr. Much appreciated. We are 2 minutes to our time, but we have had 3 fantastic presentations. And I think that here's a lesson that, you know, we need to think about how we can strengthen a public health approach. We have used it in the past, and with the advances in technology and other aspects of clinical advances, we may have neglected many of these approaches where you've got different issues collide, where you end up with this syndemic problem that requires more complex approaches in response. But those were the 3 presentations, fantastic presentations. I would like to, we've had one major question that was raised. And again, it comes back to this issue of public health to say, if you've got a country like South Africa that's demonstrating such a huge burden of disease, be it because they are tracking diseases properly than other countries, or because they really have a true burden. Regardless, we have a situation where you have borders that are leaking, and this, when one country's got a burden, it can spill into other countries that may not be as resourced, that may not be as prepared to respond. How do we deal with those issues? It's a very critical question that we'll have to think about. But again, it comes back to the issue of a public health approach. Let me thank you all for the presentation. hand back to Professor Nelson to wrap up the session for us and close. Thank you.
Thank you. Thank you very much, Mosa, for steering us through these presentations. Colleagues, time does not allow us to continue. Time is up. But let me thank all our three powerful speakers. Great presentations. But also, you people who have attended, participated in this session from wherever you are, thank you very much for sparing the time. I cannot end this session without extending very special thanks to the Secretariat of AfriHealth that are behind the scenes to organize this conference for us. And that was with the oversight of the Executive Committee, to both the Executive Committee and Secretariat. I will not name individuals, but please let's join our hands wherever we are and thank them for great work done. I hope the rest of the meeting will be stimulating, but we are left with this issue to really have a new mindset and look at things differently if this continent is going to overcome this COVID pandemic. Once again, thank you very much. And Mosa, thank you for doing a great job.
Thank you very much. Thank you, colleagues. Much appreciated. Bye, everyone. Have a good day.
Bye-bye. Thank you all.